The following podcast is part of a certified educational activity titled Level Up with Personalized Care for CLL SLL, Achieving Better Total Care with Targeted Agents and Innovative Combinations. Access the entire activity and complete the post-test at peerview.com/KBW860. Downloadable slides and practice aids are also available.
Good evening, everyone. My name is Bill Weirda. I'm from the MD Anderson Cancer Center. Welcome to our program this evening entitled Level Up with Personalized Care for CLL, Achieving Better Total Care with Targeted Agents and Innovative Combinations. I'm joined tonight by two lovely women from New York, Nicole Lamanna from Columbia University, and Megan Thompson from Memorial Sloan Kettering. So a little bit of a few introductory comments. I've been around long enough now to sort of have experienced a whole continuum of treatments for CLL, starting with chemoimmunotherapy. When I first started working at MD Anderson, Dr. Keating had developed the FCR program, and the FCR 300 were enrolling in that cohort. I'll show you a little bit of 20-year follow-up data from the FCR 300 experience. But since then, there's been sort of a revolution, not just an evolution, but a revolution in therapy for CLL, transitioning into an era of targeted therapy. And you can see several of the agents that are now approved and or about to be approved for CLL that have ushered in a very different management strategy for CLL, have remarkably improved outcomes for patients with CLL, and significantly and remarkably extended and prolonged survival for our patients. Where I'm talking more about healthcare or health maintenance and sort of health maintenance strategies for patients, more so now than I ever did, as opposed to talking about management of disease. You can see the list of the covalent BTK inhibitors that are currently approved for CLL, like ibrutinib, the first generation, and then the second generation BTK inhibitors, acalabrutinib and zanubrutinib. Pirtobrutinib now approved for mantle cell lymphoma, a non-covalent, irreversible inhibitor. We do anticipate, hopefully, approval for CLL. Nemtabrutinib is under investigation, and then venetoclax, the BCL2 inhibitor, has allowed for fixed duration targeted therapy for our patients. And we're going to talk about those different strategies in the frontline setting and the relapse setting and rational strategies for sequencing of therapy. A quick comment on prognostic factors. So historically, we've done a lot of work with prognostic factors, and I've had a lot of interest in prognostic factors over the years. And I feel that they're very important to evaluate for patients because it gives me a full picture of the patient and the patient's disease and what to expect from the patient's disease, and it allows me to have a little bit better conversation with the patient about expectations for their disease, and in some cases it's helpful in management for patients. But as you can see from this registry data, very few patients in the community are having their prognostic factor profile evaluated. 31% have FISH evaluated. Probably the most important feature for FISH is to identify 17p deletion, but there are other prognostic categories identified by FISH abnormalities. Less commonly, TP53 sequencing, also prognostic and helpful, but only 11% in this registry, and IGHV mutation status, also important, I think, for setting expectations and helping in direct therapy. I think this is important to keep in mind, and as I mentioned, I think these things are really essential to gain an understanding of patient's disease and to have a thoughtful discussion with the patient and to optimize their management. Now, when we talk about treatment and we talk about targeted therapies, we're looking currently at data with regard to the category of patients that we feel has an unmet need. Those are patients who have failed both strategies of targeted therapy, BTK inhibitors, particularly the covalent BTK inhibitors and BCL2 inhibitor, venetoclax. So we can see the progression-free survival curve here for patients who are refractory to both BTK inhibitor and BCL2 inhibitor, which is very short, on the order of, I believe it's about 6 months, median progression-free survival. And those are the patients with an unmet need, and those are the patients that we're looking for clinical trials and looking to identify more effective therapies for. I do want to touch on chemoimmunotherapy, and again, mentioning back and reflecting back on the FCR 300 experience. So the FCR 300 experience were the first 300 patients treated with FCR at MD Anderson. And these data have recently been updated by Philip Thompson and are currently in press in Blood as the 20-year experience for FCR. On the left, you can see the plateau persists for the patients in the red curve. Those are patients who have a mutated immunoglobulin gene, whereas those patients who have an unmutated immunoglobulin gene in the gray curve, you can see this relentless progression of disease. If you look over to the right, those are the survival curves, and overlapped on the red curve, which is the patients who have a mutated immunoglobulin gene, you can see from SEER data the expectation for age-matched and sex-matched individuals. And so you can see for that category of patients, we're doing very well. In fact, about half of them are cured of their disease, and their overall survival is as good as what would one expect from an unaffected population. However, chemoimmunotherapy is tough on patients. It's not potentially relevant for all patients, but I do think that there potentially is a place for it that we need to have a discussion with our patients about and think about. These are our goals for the program today. It's to discuss targeted therapy, discuss strategies for targeted therapy, optimizing targeted therapy for our patients, combination targeted therapy, and rational sequencing of treatment. I'm not going to read each of those for you, but in the interest of time, I think we'll move to our first speaker, who is my friend and colleague, Nicole Amana from Columbia University, and she's going to talk about frontline therapy.
Thank you. So we're going to take you through a series of cases and sort of illustrate, from frontline to relapse to double refractory to give you a flavor, and we'll alter them. Here's just the first in the upfront treatment setting. Here's an older gentleman, an 80-year-old person with symptomatic CLL. He has an elevated white count to 200. He's anemic to 8.5, an unmutated IgHV, a deletion 17p by FISH, and a mutated TP53 on NGS. So when we think about somebody with high-risk features, what are the potential options given his age and high-risk features? Any role for chemoimmunotherapy? And if going on a continuous BTK, what's the data and when we consider safety as well? And would you add a CD20 monoclonal antibody? And maybe I'll just say, Megan, in this situation, what do you think? Just a very quick review, because we're going to do this, but any role for chemo, just like Bill had just presented that wonderful data from FCR 300.
So in this patient, the unmutated IgHV status as well as TP53 aberrancy would rule out chemoimmunotherapy. We know those patients have poor responses to chemoimmunotherapy. And so I would not, even put that on the table for discussion here.
Fair enough. Okay, so let's go through some of the data. The NCCN guidelines, as now that Bill just mentioned, we have 3 covalent BTK inhibitors that have been approved, right? Ibrutinib was approved in 2013. It's 10 years later, everybody. And then, of course, we have acalabrutinib and zanubrutinib most recently approved in January. So again, 10 years later from ibrutinib approval. And then, of course, we have time-limited therapy with the Ven antibody combination. So you could see both in frontline and subsequent lines of therapy, both covalent BTK inhibitors and Ven-based therapy are really standard of care options for most patients with CLL. We now have longer continuous follow-up from several phase 3 studies looking at targeted therapies, covalent BTK inhibitors versus chemoimmunotherapy. And just to remind everybody, some of those studies with each of the different covalent BTK inhibitors, you have ibrutinib plus or minus rituximab versus bendamustine and rituximab. That's the Alliance study, where the 48-month PFS was 76% for ibrutinib versus 47% with bendamustine and rituximab. For acalabrutinib, you have the Elevate-TN study. That was acalabrutinib plus or minus obinutuzumab versus obinutuzumab and chlorambucil. Now the 60-month PFS of 84% with the combination of acala plus obinutuzumab, or 72% with acalabrutinib monotherapy versus a small percentage for the obinutuzumab chlorambucil. And then, of course, with zanubrutinib, the more recent covalent BTK inhibitor, you have the Sequoia study. So zanubrutinib versus bendamustine rituximab with a 42-month PFS of 82% with zanubrutinib versus 50% versus bendamustine rituximab. So as Bill alluded to, this is sort of that type of phase 3 large randomized studies showing a move away from chemoimmunotherapy because of the improvement in PFS with the covalent BTK inhibitors. Now, what about the high-risk patients? Obviously, in the era of chemoimmunotherapy, unlike the mutated patients that Bill just showed you before who can do really, really well long-term with FCR, these are the patients who would initially respond, but unfortunately the response duration was very short. And remember, at that time, we had very limited options outside of chemoimmunotherapy. We'd recycle those treatments. They'd have complex, infectious complications and marked drastic decrease in overall survival with chemoimmunotherapy. And so this, at that time, was the truly unmet need in high-risk individuals. Here now, fast forward to the BTK inhibitors, really not only transforming how we treat all patients, but in particular patients with high-risk features. So here's pooled analysis with ibrutinib from several studies with 89 patients who had deletion 17p in different studies. And you can see here at a median follow-up, the PFS and overall estimates at 4 years were 79% and 88% respectively. So this was truly, again, a game changer for patients with high-risk disease who shouldn't really be receiving any chemoimmunotherapy at this point at all. If we get in particular and start looking at these studies more closely, if you look at the Illuminate, ibrutinib, and obinutuzumab, whether the patients had a deletion 17p or TP53 mutation or not, they become really good players, almost like the patients without those features. And you can see that data on the left. And then, of course, from the cooperative group study, the ibrutinib plus or minus rituximab versus bendamustine rituximab, very similar with or without a TP53. Those patients do really very similarly with a similar PFS compared to those patients without. Now, of course, when you compare that to the bendamustine rituximab curve, you could see, and that's the solid orange curve, how poorly those patients do at the bottom with the TP53 abnormality with bendamustine and rituximab. Now, what about the second generation with acalabrutinib and zanubrutinib from some of their studies when they look at their patients with high-risk features? So in the Elevate-TN, there were 61 patients enrolled on that study, and you can see the median PFS wasn't reached for the acalabrutinib plus or minus obinutuzumab versus 17.5 months for chlorambucil and obinutuzumab. With Sequoia, they had an arm C, which is a very large cohort of 17p patients, 110 patients, and the median PFS has not yet been reached for that cohort. Now, what about time-limited therapy, right? That's the other major option of treatment that we're offering patients nowadays. So this is after the CLL14 study. This is venetoclax and obinutuzumab, which is a 12-month time-limited approach. And you can see how well patients do now that we have a 5-year follow-up, a 5-year PFS. Patients obviously do much better than the obinutuzumab chlorambucil arm. But here you can see a bigger split between the patients who are on the venetoclax obinutuzumab who do not have a 17p or TP53 versus those who do. So the 5-year PFS is 40% for the patients with deletion 17p TP53 versus 65% for the patients on venetoclax obinutuzumab who don't have high-risk features. So you need to keep that in mind. Now, obviously, these are not randomized compared to the covalent BTK studies I just showed you before, but there seems to be more of a drop-off with the time-limited approach in the high-risk individuals, but certainly far better than the orange curves with obinutuzumab and chlorambucil. So still a much better treatment option for patients, even with high-risk disease. Now, what about, people always ask about antibody therapy along with the BTK inhibitor. And certainly from many of the earlier studies with ibrutinib plus or minus rituximab, there didn't seem to be an additional benefit to the addition of rituximab to ibrutinib. However, with the Elevate-TN study, acalabrutinib plus or minus obinutuzumab, there seemed to be a little bit of a split between the combination versus the acalabrutinib monotherapy arm. And so if you want to, people always ask us, do you give an antibody if you're giving a chronic continuous therapy? Now, many of us may not do that because if somebody is going to be on chronic continuous therapy and wanting a pill and not want intravenous medication, and that was the luxury of not getting an IV component to the therapy and you're staying on indefinite therapy, that was most of us would just give monotherapy. During COVID, oftentimes we would avoid the antibody. So there were obviously reasons for just chronic continuous BTK inhibitor-based therapy. But if you're going to look at the data, for higher risk individuals, here's an analysis that shows it might be more beneficial in the patients with unmutated IgHV and for higher risk individuals. And so this is where you might also consider adding an antibody with this type of data. And obviously there are many studies that are looking at the combinations or adding even as consolidation an anti-CD20 into the BTK inhibitor. So stay tuned for more data with that. Now, what about obviously the off-target effects? We all know about the adverse events with the BTK inhibitors as a class. Obviously, the more selective BTK inhibitors have less off-target effects. We teach our patients about all the different adverse events that we know about from this class. Regardless of the frequency and the differences between the agents, we still teach our patients. We talk about the cardiac issues, atrial fibrillation, ventricular arrhythmias, the increased bleeding issues, arthralgias, increased blood pressure, hypertension, infection, which kind of coincides, increased infections with CLL patients in general, but certainly not unique to BTK inhibitors. And we've seen it with other therapies in addition, and of course, GI side effects as well. We try to recommend not giving concomitant warfarin when somebody's on a BTK inhibitor. If you develop cardiac issues, we try to recommend non-warfarin anticoagulation and co-management with a cardiologist, of course, management for hypertension, making sure patients are well controlled. It doesn't mean you have to stop the BTK inhibitor if somebody develops atrial fibrillation, although obviously, as Bill notes, we start talking more about side effect management than treatment because there are so many options. This becomes a discussion with your patients about whether or not they want to stay on a BTK inhibitor if they develop atrial fibrillation or move to a different agent if they've never been on medicines to control AFib or anticoagulation. It becomes a little bit of an easier discussion when you have older patients who are already on, non-warfarin anticoagulation for whatever reason, or maybe you're already on antihypertensive, then they develop AFib, and then you can co-manage. So it is more of a discussion in the clinic when patients do develop some of these side effects. And of course, you're gonna talk to them about their increased risk of bleeding, and if they have any surgical procedures that need to be done, you're gonna counsel them about how long to hold their BTK inhibitor. We always counsel them about signs or symptoms of an infection and prompt notification of those, and of course, secondary malignancies and evaluation for healthcare maintenance. Of course, uniquely, we talk a little bit about the differences between the BTK inhibitors. Acalabrutinib, people can start, so when they initiate the drug, can sometimes have headaches, and those are usually readily managed with acetaminophen and caffeine. It's rare to have to take somebody off the drug for that. Zanubrutinib has a little bit more myelosuppression compared to the other covalent BTK inhibitors. So we talk about neutropenia and sometimes the need for dose reduction or growth factor support. And of course, you've seen there's been data from several groups looking at switching. So if somebody develops an intolerance to a BTK inhibitor, remember ibrutinib was the first to market. So then there were subsequent studies looking at acalabrutinib or zanubrutinib for patients who developed ibrutinib intolerance. And certainly, if somebody is having a very good efficacy from the agent and from the class, we try to extend that management if possible before going on to another agent. Remember, many of your CLL patients are going to go from one therapy to another therapy. None of these are curative yet. And so as we tweak the combinations, if you have a young patient with CLL, they're likely going to see BTK, covalent BTK, then, and perhaps others, non-covalent and so on, and newer agents. So you need to keep that in mind. Obviously, if somebody's having a life-threatening serious adverse event, you're probably not going to switch them to a similar agent. Somebody has a CNS hemorrhage, we're probably not going to feel comfortable going to another covalent BTK inhibitor. Now, there's head-to-head data, as you all know. The Elevate-RR was the study looking at acalabrutinib versus ibrutinib in the relapse refractory setting in high-risk individuals. Median prior therapy here was 2. Here at 40 months of follow-up, acalabrutinib was non-inferior to ibrutinib. And with regards to the adverse events, there was a lower incidence of adverse events with acalabrutinib versus ibrutinib in this study, particularly the cardiac issues, atrial fibrillation, atrial flutter, but also of hypertension, bleeding, diarrhea, and arthralgias. And there were less treatment discontinuations because of adverse events with acalabrutinib versus ibrutinib on this study. Similarly, there was another head-to-head study in the relapse setting with zanubrutinib versus ibrutinib, less heavily pretreated patient population. The median prior regimens was 1, also high risk, and at a median of follow-up at 29 months now, the PFS was improved with zanubrutinib versus ibrutinib at 79 versus 67 months, and obviously we'll need continued follow-up on this. But regarding the safety issues, again, lower rates of cardiac issues, in particular atrial fibrillation and atrial flutter, with zanubrutinib compared to ibrutinib. Now, notably, there was not a difference in hypertension or bleeding on this, but there was overall less treatment discontinuation due to adverse events with zanubrutinib versus ibrutinib on the study. Now, what about drug-drug interactions? This is very common, right? So we have older patient population, the median age of 72. Many are on lots of different types of medications. Always important to review all their medications, whether they're prescribed or non-prescribed, over-the-counter medications, looking for, whether or not they are strong CYP3A4 inhibitors or inducers. And so if need be, they need to be, their drugs may need to be dose reduced, or depending upon what other drugs they might be on, could they be changed and altered if you talk to their other specialists or doctors who have them on other drugs. Gastric acid reducing agents shouldn't be a problem any longer. Now we have a new formulation of acalabrutinib. So for all the covalent BTK inhibitors, this shouldn't be an issue any longer. But again, very, very important to review drug-drug issues. So let's go back to our gentleman. So here you have an 80-year-old gentleman. Take note of this because Bill and Megan will present tweaks to the patient case. There's an 80-year-old gentleman, high white count, who's anemic. He's high risk. He's unmutated, deletion 17p, mutated TP53. Obviously, the data shows very strongly that chronic continuous BTK inhibitors are effective in the patients with high-risk disease. Second-generation BTK inhibitors are obviously more tolerable for cardiac issues and for some of the other adverse events. And so, this is certainly a suitable choice in this patient. No role for chemoimmunotherapy based on the data that we were discussing. You could do obinutuzumab. It's not off the table. Remember, I think what we're going to see in subsequent talks is whether or not it's the right combination for high-risk disease. There might be better partners that might make it more tolerable to do a time-limited therapy in high-risk individuals. And it may be that VenG might just be a little bit more problematic in an 80-year-old who's got to come back and forth and have TLS monitoring and so on and so forth because of the VenG. So those are considerations as well. So I'm going to pass this over back to Bill to talk about fixed duration platforms.
So we continue.
Yeah,
Yes. So over the next 10 minutes or so, I'm going to talk about fixed duration treatment and combination targeted therapy strategies. The patient is a similar patient, but younger, 70 years old, white count's the same, 200, hemoglobin 8.5, has an unmutated immunoglobulin gene 17p deletion by FISH, and mutated TP53 by NGS. I think a couple of teaching points with regard to this case that I'll make in regard to the prognostic factor profiling. When I see a patient with these features, I do anticipate that they will progress. They'll have progressive disease. If I see them early and they don't have any indications for treatment, I'll be having a conversation with the patient about, yes, I do expect that you'll need to have treatment. You have an unmutated immunoglobulin gene. Most patients who have an unmutated immunoglobulin gene eventually need treatment. Those with a 17p deletion in addition and mutated TP53 usually have a shorter time to first treatment. And that's in contrast to a patient who may have 17p deletion, but a mutated immunoglobulin gene. That patient may be monitored and observed for several years and not need treatment. So maybe Nicole, can you comment, would you expect a different recommendation for treatment for a 70-year-old as opposed to the 80-year-old with the same prognostic factor profile and need for treatment?
No, I agree with, I think the older individual we had before you could get away with because he's going to have a shorter overall survival because he's 80. But this one, yes, I would anticipate that he might go from one treatment to another because he is younger and he's got high-risk features. And so, and hopefully you're going to show us how other platforms might be better for this.
And to point out, this age distinction was very relevant for chemoimmunotherapy because we had low-intensity regimens and more intensive regimens like FCR. The NCCN guidelines changed recently because we removed the age categorization as we went away from chemoimmunotherapy more to targeted therapy, where we know those agents are well tolerated in the elderly population. You usually see more toxicity in the older population among the ones that we see with the targeted therapy, but in general, they're well tolerated across the age spectrum. A little bit about goals of therapy, and again, we're going to talk about fixed duration treatment. Fixed duration has an objective of getting patients in remission. The deeper, the better. the higher the percentage of patients in a remission, and the deeper the remission, the better, and the expectation for longer progression-free survival and potentially overall survival. So you saw a little bit of this data a few minutes ago. This is CLL14. There was a recent update, a 6-year follow-up. This is venetoclax-based therapy, so it's venetoclax for 12 cycles with 6 cycles of obinutuzumab. It was a randomized trial comparing that treatment to chemoimmunotherapy with chlorambucil obinutuzumab. You can see a median progression-free survival for the non-chemotherapy venetoclax obinutuzumab regimen of about 6 years, which is very good with a fixed duration, 1 year of treatment. About 75% of these patients achieve an undetectable MRD status at the end of treatment in the blood, and that does correlate with a long progression-free survival. And in contrast, you can see a shorter progression-free survival for the chemoimmunotherapy regimen. I will point out, and Nicole showed the data, where for the whole population, 6 years the median progression-free survival. For patients with 17p deletion, it's a little bit more than 4 years. So it's a 2-year, you lose about 2 years in terms of the progression-free survival if you're looking at patients, the subgroup of patients with 17p deletion. So they do have a shorter progression-free survival. So a little bit about combinations. And so one question is, how can we improve on venetoclax obinutuzumab? When I think about venetoclax, it's fixed duration, and we're thinking about and talking about how do we optimize that strategy. One of the approaches that we took at Anderson early on was to look at the combination of BTK inhibitor. Ibrutinib was the available BTK inhibitor at the time, combined with venetoclax. And so we evaluated that combination in previously treated patients as well as previously untreated patients. And we have long-term follow-up data from those results. The agents are complementary in terms of in vitro studies that show synergy between the two agents. In terms of clinical activity, where ibrutinib has very good activity against lymph node disease, it's not as good at clearing out blood and marrow disease, where venetoclax is highly effective at clearing marrow and blood disease. And so the clinical complementarity, the non-overlapping toxicity, and then the in vitro synergy led to the evaluation of that combination, again, in treatment-naive patients and in relapse patients. We have, this is a 4-year follow-up from the MD Anderson cohort of 120 patients who received that combination, 3 months of ibrutinib, and then 24 cycles, or about 2 years of combined therapy. On the left is the progression-free survival, and you can see very good progression-free survival, about 95% progression-free at 4 years. If you look to the right, you can see patients categorized by their 17p status. This is 2 years of therapy as opposed to CLL14 and as opposed to the Captivate data that I'll show you in a minute. But you see exceptional outcomes, including for patients with a 17p deletion. Those are patients in the blue curve that have 17p deletion as opposed to the non-17p deleted patients in the red curve. Not statistically significantly different in terms of progression-free survival at the 4-year readout. And the follow-up continues on this trial. The Captivate trial was a large multi-center trial with a similar strategy of 3 months of ibrutinib and then combined therapy for 12 cycles of ibrutinib plus venetoclax. There were 2 cohorts in this trial, an MRD cohort where patients were randomized based on their MRD status at the end of that 1 year of combined therapy, and a fixed duration cohort where all the patients received 12 cycles of combined therapy and stopped. And so this is a 4-year follow-up from the Captivate fixed duration cohort. So all the patients received the same therapy. They weren't randomized. You see very similar responses on this trial as in other multi-center trials and at the 1-year time point for our MD Anderson trial. And to the far right, you can see the progression-free survival curves. The green curve is patients who have a 17p deletion, which appears to be progressing a little bit earlier than the others. And so 1 year of fixed duration treatment, very effective for 17p deletion. Looks like it might be better than venetoclax obinutuzumab in the data that Nicole showed you. I think one of the points of debate is what's the optimal duration of therapy? how long do you give therapy with these combinations to optimize the outcomes for the patients? And I think it depends on the patient characteristics, and it may be longer for patients with 17p deletion than the non-17p deleted patients. Very well tolerated combination. The GLOW trial was a randomized phase 3 trial that evaluated this combination, ibrutinib 3 months, combined therapy for 12 cycles, versus chlorambucil obinutuzumab. And the outcomes were improved for progression-free survival for those patients who received the combined targeted therapy. And these are the tolerability and toxicity data. And you can see a little bit higher incidence of infections with the ibrutinib venetoclax cohort. And there were, as expected, cases of atrial fibrillation that we associate with ibrutinib reported in this trial and in other trials. I don't think that we will see this combination approved in the US by the FDA, but we have seen it approved in Europe. And I think what we will see moving forward is there are numerous trials that are ongoing, that are phase 3 trials, that are evaluating these combinations of targeted therapy. And from those trials that read out over the next 5 years or so, we'll have a better idea about optimized combination targeted therapies. One comment about the GLOW trial relates to the MRD data. This is MRD for the ibrutinib venetoclax cohort. On the left are patients who have an unmutated immunoglobulin gene, historically considered the high risk. On the right are patients with a mutated immunoglobulin gene. And what you can notice here is that at the end of treatment, which is highlighted in the red square, a higher undetectable MRD rate for patients who receive the combination who have an unmutated immunoglobulin gene. So it appears that it's a little bit more active a regimen compared to those patients who have a mutated immunoglobulin gene, if you're looking at MRD at the end of the fixed duration treatment period. So I think that's an important observation from this trial. The other important observation from the trial is if you look at MRD status with follow-up, those patients who have an unmutated immunoglobulin gene tend to lose their MRD undetectable status with longer follow-up quicker than those who have a mutated immunoglobulin gene. So you see a steeper fall off on that undetectable status for the unmutated cases compared to the mutated cases who sort of hover at the same rate for a longer period of time. So that's ibrutinib venetoclax. There are other combination regimens that have been evaluated. Acalabrutinib, a second-generation BTK inhibitor with venetoclax and obinutuzumab, was studied by the Dana-Farber group and reported by Matt Davids, with very high incidence of undetectable MRD status by end of treatment, including in patients with high-risk features like 17p deletion, as you can see by those orange bars to the right of that figure. So almost 90% undetectable MRD with this combination. What we need to see is the longer follow-up, and what we also need to see is randomized data to clarify what's the optimal strategy. Do we do a doublet? Do we do the triplet? Is it the triplet for everyone, etc.? So again, we'll see those data moving forward in the future, in the near future. The other study is zanubrutinib, venetoclax, and obinutuzumab. This has been termed the bovin study. That triplet evaluated in previously untreated patients. And again, you can see a very high response rate, high CR rate, high undetectable rate for patients receiving this combination with very durable remissions, as you can see to the right. The orange part of those swimmer's lanes are undetectable MRD remissions. There's been one patient that reinitiated on treatment, you can see about midway down, and there's a couple patients who've continued treatment a little bit lower than that. But a very active regimen, and again, the question is, how do we optimize these combination targeted therapies? So back to the case and a little bit of a few points about the case. I think you see from the fixed duration, very active regimen in patients with high-risk features, including patients with 17p deletion. Patients who don't have those high-risk features do exceptionally well. My preference is to get a patient in remission. get them off treatment, get them on observation. In 5 years, in 7 years, we can talk about how to manage that patient if and when they relapse and they need retreatment. And those options are going to be different than they are today, for sure. And so you can see here some of the take-home messages: optimizing the duration of treatment, optimizing the regimen, identifying which patient population do best with a treatment will be what we will look for the trials that are reading out in the near future. I think the other point to make with regard to this case and 17P in general is that recently a lot of us have talked about managing those patients on continuous maintenance therapy. You've seen from the data that I've shown you, they do well with fixed duration therapy, but a lot of us haven't yet developed great comfort with getting those patients off treatment and prefer to have them on some maintenance. So you'll hear that discussion and debate about what's the optimal way to manage these patients. I think the other point to make is that 17P is very uncommon in the frontline setting. It's about 5 to 8% of patients who are previously untreated with CLL. So most of your patients won't have that characteristic or feature. We see an unmutated immunoglobulin gene, which is, I think we have to think of as also a higher risk for shorter remission duration with fixed duration. You'll see that in about 60% of patients who need treatment. Next up is Megan Thompson from Memorial Sloan Kettering. Megan?
She has to say it.
Okay, thank you so much. So we're gonna delve back to our 70-year-old patient. And this time we're gonna have two scenarios. So most of you selected that this patient would get a covalent BTK inhibitor. And in scenario one, this is again our 7-year-old patient, unmutated IGHV status, TP53 aberrancy with both deletion 17p and TP53 mutation, receives a covalent BTK inhibitor for 3 years, and has progression during treatment. So how will we treat this patient? And we'll review the evidence for that. And then in scenario 2, taking it a step further, this covalent BTK inhibitor treated patient progresses and then receives a venetoclax-based regimen with a 2-year fixed duration Mirana regimen, and subsequently has a short treatment-free remission but then progresses. So, points for discussion that we'll review: what factors should guide treatment selection in a patient who progresses on a covalent BTK inhibitor? Should you switch to a venetoclax-based regimen or now considered a non-covalent BTK inhibitor? And then what about testing for BTK inhibitor resistance? Should this be part of clinical practice? Does it change your treatment decision-making? And then in the second scenario, how do we define a patient who has had both a covalent inhibitor and venetoclax, a double-exposed patient versus a double-refractory patient? And could we consider venetoclax retreatment in some of these scenarios? So, Bill, what do you think about just weighing in on the first scenario, considering a venetoclax-based regimen or considering a non-covalent BTK inhibitor, just as a preview of what we'll talk about?
In terms of frontline therapy, what's my preference?
After progression on a covalent inhibitor.
Okay, after progression on a covalent inhibitor, so those patients are refractory to the BTK inhibitor. Usually they'll have a mutation in BTK, and there's data that supports venetoclax-based therapy for those patients. There's also emerging data supporting the non-covalent BTK inhibitor. I think that's a controversial topic, whether you stay in target and extend out your in-target time on treatment and then reserve venetoclax-based therapy for later, or you move to the other therapy, and then later on you can move back to the targeted therapy with the BTK, the non-covalent BTK. My preference would be to give venetoclax at that point, but there's not data that informs it, and I think that's a debatable topic.
Okay, so let's review some of that evidence. So first to start, some of what Dr. Weirdo was alluding to is that we now know for patients with progression on covalent BTK inhibitors, and most of the work has been done actually with ibrutinib, that at the time of clinical disease progression, about 50 to 80% of patients have acquired mutations in the BTK target protein at the cysteine 481 position. That's the binding site for ibrutinib. BTK cysteine 481S is the most common mutation. This leads to increased phosphorylation of BTK. It's a catalytically activating mutation, increased B cell receptor signaling. And then in a smaller proportion of patients, they may acquire mutations in PCL gamma 2, which is the protein immediately downstream of BTK. And this data from the Elevate-RR trial, small number of patients, but sequenced with similar methods, and shows that for both acalabrutinib and ibrutinib treated patients, at the time of clinical disease progression, BTK cysteine 481S mutations remain the most common, but you can see there's some subtle differences between the acalabrutinib and the ibrutinib cohort in terms of co-mutations with BTK cysteine 481, and then some other emerging mutations, for example, BTK L528W and A428D, which are kinase dead mutations with a little bit of functionally different consequences for BTK signaling. So this map here of the BTK pathway is a little bit complicated, but I want you to focus in just on the BTK protein up at the top. And if you look at that tyrosine kinase domain, there's a lot of different mutations that have begun to crop up with covalent and non-covalent inhibitors. So this is just to highlight that there's a little bit of emerging heterogeneity and resistance mutations to BTK. So while cysteine 481S mutations are the most common and also seen in acalabrutinib and zanubrutinib treated patients, we do know that in zanubrutinib treated patients, for example, a small number of patients also have acquired BTK L528W mutations. And so while BTK resistance testing is not currently standard of care, there is some overlap we're seeing between covalent and non-covalent resistance mutations. And I think in the future, this might play a role as we learn more in BTK inhibitor selection and sequencing. So this is the current NCCN guideline algorithm for treatment of relapse CLL. And so after progression on a covalent BTK inhibitor for a high-risk patient with P53 aberrancy, venetoclax-based regimens are the preferred listed regimens, but you'll note that now pirtobrutinib as a non-covalent BTK inhibitor is now listed useful in certain circumstances. So we'll review the data for both of these regimens. So here's a prospective phase 2 trial looking at venetoclax in patients with CLL previously treated with ibrutinib. So this is really prospective, the first prospective data to support venetoclax after ibrutinib or covalent BTK inhibitor to ven sequencing. This was a heavily pretreated patient population, median of 4 prior therapies, did include several patients with P53 aberrancy, median PFS of just over 2 years here. Here is the phase 3 Murano trial data. So this was the registrational trial, venetoclax and rituximab for a 2-year fixed duration compared to the chemoimmunotherapy control bendamustine rituximab. You can see the PFS curves on the left, the overall survival curves on the right, venetoclax and rituximab outperforming the chemoimmunotherapy arm. I think it's always important to note when we're talking about applying this to patients, as a reminder that only 5 patients in the Ven-R arm in this trial had prior B-cell receptor inhibitors. So these weren't patients previously treated with ibrutinib, but really excellent outcomes we now know from prospective and retrospective data for venetoclax activity after ibrutinib. So there's a lot of experience here to support the covalent inhibitor to ven sequence. But non-covalent inhibitors also may have a role here, and were designed to bind reversibly to the BTK protein, so a different binding modality than the covalent inhibitors, and do seek to address some of the limitations we've already discussed during this talk: acquired resistance, intolerance or discontinuation of BTK inhibitors for adverse events, and then this emerging category of the double-exposed CLL patients previously with exposure treatment to a covalent BTK inhibitor, venetoclax. So I'm going to review the data for the non-covalent inhibitor furthest along in clinical development, pirtobrutinib, which is highly selective, has a longer half-life than ibrutinib. And this is data from the Bruin study. This is the most updated data, 247 patients. All patients reported on here did have prior treatment with a BTK inhibitor. So this data is very applicable to the sequence we're talking about with our patient case here. This is the waterfall plot. The different colors here highlight different reasons for discontinuation of the prior inhibitor. So you can see responses with an overall response rate of 82% in patients with both BTK inhibitor resistance as well as discontinuation for intolerance. And there's also clinical activity regardless of prior BTK mutational status, whether or not they had a cysteine 481 mutation or not. This is a PFS data. So now at a median follow-up of about 19 months, median progression-free survival of 19.6 months. This is in the overall cohort of prior BTK inhibitor exposed patients. And this is in patients with prior exposure to a BTK inhibitor and BCL2 inhibitor, which is about 40% of the Bruin study population. A median of 5 prior lines of therapy, so very heavily pretreated patient population. A little bit shorter follow-up, around 18 months for this cohort. Median progression-free survival of 16.8 months in double-exposed CLL. So when compared, this is a phase 2 study, but when comparing it to currently available standard of care options for this patient population, there's retrospective studies, for example, reporting median progression-free survival we saw of 5.5 months in this patient population overall, and also around 5 months with PI3 kinase inhibitors. Overall, the experience so far in terms of safety has been quite good with pirtobrutinib. Just about 3% of the Bruin study population discontinued drug for AEs, which compared to other BTK inhibitor trials with the caveat that its shorter follow-up is quite good. The most common grade 3 or higher AE experience was neutropenia, and in clinical practice, this can, and on the protocol as well, this was able to be managed with growth factor. So we are starting to see some resistance, though, develop to the non-covalent BTK inhibitors. This is based on work from our group at Memorial, where we took patients treated with pirtobrutinib on the Bruin study, and at the time of clinical disease progression, did identify several different BTK mutations in the tyrosine kinase domain of the protein. Several of these mutations, L528W, you heard earlier in the talk, because are also being seen to a certain extent with some of the covalent inhibitors, and beyond the scope of this talk, have different functional consequences than the cysteine 481 mutation that is most common with ibrutinib and acalabrutinib. We've also found several patients with progressive disease having pre-existing PCL2 mutations that persist at the time of disease progression. So I think this data overall, while it's preliminary and there's been some updates in the larger Bruin study presented, will be important and when we talk about sequencing and selection of BTK inhibitors in the future. So for patients who've had venetoclax exposure in the past but discontinued venetoclax for reasons other than disease progression, that is, they didn't have progression of their CLL while on the inhibitor itself, the question becomes, can you recycle a therapy? So I think that this is relevant to talking about the fixed duration treatments, whether it's, upfront venetoclax or venetuzumab, using the Murano regimen as a 2-year fixed duration in the relapse setting, and maybe even, a little future thinking with the BTK BCL2 combinations. How do we manage these patients? So this is retrospective evidence looking at patients who were retreated with venetoclax. This was a heavily pretreated patient population looked at here. Over half of the patient population had been exposed to a BTK inhibitor before. There was a median of 16 months between the start of the initial venetoclax and venetoclax retreatment, and a median progression-free survival of 25 months. What the correct duration is between the end of the prior venetoclax treatment and the beginning of a venetoclax retreatment is an outstanding, clinical question that we need to further investigate. And that kind of plays into this concept that we were talking about earlier, double exposed versus double refractory patients. So a double refractory patient we can say as a patient who has relapsed CLL, who progressed on both treatment modalities, a covalent inhibitor, and had disease progression on venetoclax. A double exposed patient has been exposed to both therapies, but may or may not be resistant truly to both modalities. So there's a subgroup of patients, for example, who discontinue venetoclax for completion of planned therapy rather than disease progression. And what the optimal treatment-free remission to be considered refractory versus exposed, I think, is still debatable. Many people have cited 24 months as a number by expert opinion, but we really need more data to better define this. And when we really can turn back to venetoclax retreatment versus switching to another treatment modality. So just to touch on this double refractory CLL space, there's many agents that are in clinical development currently. We talked about the non-covalent BTK inhibitor pirtobrutinib, which is now NCCN listed, as you saw, not yet FDA approved. Nemtabrutinib is a non-covalent inhibitor in clinical trials. CAR T-cell therapy, specifically CD19-directed CAR T-cell therapy, for example, liso-cel. There were double refractory CLL patients treated on this study, and there have been very durable responses in some of those patients. BTK degraders are first in human clinical trials, looking at ways to overcome those BTK mutations that cause resistance. And then bispecific antibodies have shown a lot of promise in lymphomas and are now being explored in CLL. So just to recap our clinical case here, for patients who progress on a covalent BTK inhibitor, there's data to support sequencing to a venetoclax platform or a non-covalent BTK inhibitor. I think there's more experience with venetoclax, but the Bruin study did include 247 patients who were previously treated with a BTK inhibitor, so there are data to support use in that setting. We don't have any randomized data, and a lot of future trials are going to have to explore sequencing in this clinical question. For double exposed CLL, so in the scenario 2, if there was just a short treatment free remission after completion of venetoclax, say less than 2 years, it does make sense to switch to a different treatment modality. But if there's a longer treatment free remission, say 3 years after completion of venetoclax retreatment may be an option, and prospective validation of that strategy is ongoing.
Great, thank you, Megan. We have time for a few questions. I think we're going to finish at 35 minutes after, so if you have any questions, submit them through the QR code and I'll be happy to read them. I don't see any questions yet. Maybe I can ask a couple questions, or ask maybe Nicole. I'll give you a chance to take a breather, Megan. Nicole, can you comment on if you have a patient who's been on a covalent BTK inhibitor, Frontline, is progressing, their white count's starting to rise, their nodes are starting to grow, what strategy do you use in terms of transitioning that patient over to the next treatment, whether you're going on a non-covalent BTK inhibitor or venetoclax-based therapy?
Okay, so that's fair. So I think that one of the points to mention is that obviously if somebody's starting to progress, now if they have high-risk disease, they're probably going to progress a lot quicker. So if somebody's got 17p or p53 or complex karyotype, their progression may go a little faster versus somebody who may have favorable risk characteristics. And sometimes you can actually watch those individuals, even if their white count's going up. It's almost like they're still on active observation, but they're slowly progressing, and they don't meet indications for therapy by IWCLL criteria. And you can actually, some of those guys can buy more time on a covalent BTK inhibitor. But I think what Bill's trying to bring up is, as sometimes, remember, if you stop the BTK inhibitor, and this also depends in part on their disease burden as well, some of those patients may have a rebound or a flare, or you might need to bridge them. And so some people might need to be overlapped if you're going to switch them to a different form of therapy, whether that be, a ven-based regimen. You might want to overlap in that fashion. Others, you might be able to get away with a discontinuation, but a short, I think one of the challenges we had when actually venetoclax came available in the phase 1, phase 2 studies was that the studies required you to be off of therapy for at least a week. And some of those individuals, remember, ven required a ramp up. And so in the early phase studies, the patients were blowing through because their disease was becoming very aggressive quickly, and we couldn't wait to get to the next week of 20 milligrams, 50 milligrams. And so you really had to bridge them, whether it be with steroids or continuing the BTK. So you just need to think about that, as some of the individuals might need to be bridged if you're going to switch their therapy, because they might have a rapid progression and they're not really failing the venetoclax ramp up. It's just that they're not getting enough drug into them quick enough. Now, you can also, if you're going to go to a ven-based strategy in that fashion, you can also swap the way you're doing this. And certainly you could front load the antibody in a sense and get their disease under control, so that you'll have enough time then for the ven to ramp up and you won't have to worry about that. So there's multiple ways or arts of medicine to do this, but that's one of the points you need to remember. You might have to bridge some of your folks and not just, frankly, discontinue the BTKs, particularly if they're multiply relapsed.
So we actually have a lot of questions here. Many of them come from our virtual audience. So Megan, what's your experience in dose modifying second generation BTK inhibitors to address adverse events? So maybe you can sort of review the adverse events that we see with the covalent inhibitors and dose adjustment and where that's appropriate.
Yeah. So I think that's a great point. For ibrutinib, there's probably the most data out there on dose reductions and guidelines. For the second generation covalent inhibitors, though, acalabrutinib, for example, it's 100 milligrams BID. Given the half-life of the drug, there's not really by the label as much flexibility in dose reducing the drug. I think a lot of us have been able to manage the AEs, with other tricks or tips. For example, headache with caffeine and Tylenol rather than going for a dose modification. Very occasionally, I have had a patient on acalabrutinib 100 milligrams daily, but that's not really a data-driven approach. Zanubrutinib with twice, there's two dosings. There's the twice daily dosing and then daily dosing as well. You can also, again, try for dose modification, but I think a lot of progress has been made in terms of managing AEs without going to that dose modification. Other strategies for the adverse events, especially neutropenia, for example, with zanubrutinib, using growth factor. So it's, again, one of these art things and kind of patient specific about whether they'll stay on the drug in 2023 or go to an alternative therapy.
Great. So we heard a little bit about BTK mutations and resistance. Nicole, can you comment on the utility of evaluating for BTK mutations, when you might do it, and how it might be clinically relevant in practice?
Yeah, I mean, so this is an evolving field, obviously. I mean, for the most of patients, if you're going to, I think for us, we do check for resistant mutations. However, this is more of an academic question to gather data. Most patients, if they're failing a covalent BTK inhibitor because they have progressive disease, regardless if you identify that they have a BTK C481S mutation or one of the other mutations, you're still going to be switching them off a covalent BTK inhibitor. So again, academic questions going to help us, I think, down the road for sequencing of drugs. Right now, routinely, probably not yet for mainstream. Stay tuned, but you're going to move away from, you're not going to give them another covalent BTK inhibitor if they're failing a current covalent BTK inhibitor. So in practice, you're going to move away from it. So is the utility of drawing it and knowing it until we show that there's a reason to do that? Probably not so much, but we tend to do it in academia because we're trying to see what the best sequence is and how to maneuver drugs. But for practice, you're going to move away.
I'm going to give each one of you one more question. There's a lot of great questions, but I think we're at the end of our time. So Megan, any role for pirtobrutinib in the frontline setting?
Definitely a clinical trial question. And there is an ongoing clinical trial looking at pirtobrutinib versus ibrutinib in the frontline setting. So we'll have data on this. So today, no, because we don't have the data, I would say. And I think we're just going to have to await the results of clinical trials. And I think this is where some of that resistance mutation profiling might ultimately fit in, but not in 2023.
Nicole, the PI3 kinase inhibitors we've had for a while, we didn't talk a lot about them. Can you just comment perhaps on, is there a role for them these days?
Are you asking me that because I'm old and on Cal 101 from the beginning? Obviously, the PI3 kinase inhibitors, very active agents. We had a lot of great data with idelalisib, which was obviously the first to market. But as many of you note they had certain toxicities that became difficult to manage, particularly the GI toxicities and the colitis and the diarrhea issues that when we talk about obviously chronic continuous therapy, people would come off due to, discontinuation, just like we talk about ibrutinib. So the upfront studies with the PI3 kinase inhibitors, unfortunately, there was infectious complications and increased deaths, and so the studies were halted. So right now, in the relapse setting, I think that, you could still potentially use it. The issue is that, remember, they are also B-cell receptor pathway inhibitors. So if they're failing a covalent BTK inhibitor, we do have data in the retrospective cohort series that shows that you can go to a PI3 kinase, but the response duration probably won't be very long. So you have to look at it as a bridge. So if you're going to bridge it to an alternative therapy, that's fine, but the response duration won't be very long, so you should just know that. So I think right now it'll remain in the relapse setting, of course, but there are other agents coming down the pike. So then the question is, how far does it get pushed?
Great. So thank you. I would like to thank PeerView and the sponsors for this event. I'd like to thank the audience and our virtual audience for spending the evening with us. I'd like to thank Megan and Nicole for their excellent presentation and discussion, and hope you have a good rest of the Soho meeting. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KBW860. This activity is supported by independent educational grants from AstraZeneca, Beijing, Pharmacyclics LLC, an AbbVie company, and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Lilly.